thought we could talk about off-label use of ICL because as surgeons become more comfortable with the technology, more of this will be more common. So just to review, the FDA indications currently are ages 21 through 45, internal ACD of 3.0 millimeters or greater, again that's endothelium to anterior lens capsule, spherical equivalent -3 to 16, and healthy eyes. So we personally are comfortable with ages 18 to 59. Blended vision works very well in ICL patients. We are okay with internal ACDs down to 2.4 depending on anatomy. Our personal philosophy is 2.8 and above is really the same as the rest of the world. Europe, for example, the approval for ICLs is 2.8 and above. Anything under 2.8, specifically 2.6 to 2.8, we will not do immediately sequential bilateral surgery and just do one eye at a time. And then of course we make sure the eyes are healthy overall and we obtain specific off-label consent. So I thought we'd just go through a case of an off-label ACD just to review how we approach this. So here's a patient with an anterior chamber depth of 2.77 and 2.7. The right eye is non-toric and the left eye is toric in this case is what we're planning here. For this case, we use the London Vision nomogram, which is available online. And you can see, 13.2 looks like a reasonable vault. Sometimes my gut specifically is to hedge down when the ACD is under 3.0. And to be strategic, the decision was made to do the right eye that's not toric first. So here is that case afterwards. This is the 12.6 millimeter ICL inside the eye. And the next morning, you just check with a slit lamp, but I, for academic purposes, actually obtained a vault and it's about 125 microns. Because of this result, the decision was made on the day of surgery to switch to the 13.2 for the toric eye. So here you can see the toric markings, and this is the larger lens size. So when the patient comes back for proper vaulting and post-op measurements, we can see the right eye actually is pretty close to what it predicted for that 12.6 size, and the 13.2 eye is a little higher than it predicted, but both of these are okay. If we look at this MS39 scan of the anterior chamber, we already can suspect the right eye is going to be fantastic, and here it's 24 degrees, which is awesome. The vault is totally okay, another perk of EVO, with the central port allowing always a layer of aqueous between the crystalline lens and the ICL. And then in the left eye, this is also fantastic. Even with a higher vault, we're still seeing a 20-degree angle, which is an awesome result. This emphasizes two things. One, an approach like this, when you're confident with the technology, can lead to some awesome outcomes, even in off-label uses of the ICL, as long as the whole team and the patient is understanding. And two, EVO is so tolerant to different vaults. We're not worried about this at all. The fact that the lens will always be sitting on a layer of aqueous between the crystalline lens and the ICL means there is very little risk in this case. These angles are plenty open, and this patient's outcome was fantastic.